Good morning, everyone. Good afternoon and good evening. We have the distinct privilege of having people from all around the world. I see some friends from Myanmar and Thailand, from India, from the United States, from South America. This is lovely, and I know it's hard to find a time that works for everyone. We feel especially for Allyn Auslander, our presenter this morning in Los Angeles. I believe it's about 5 a.m. this morning. Allyn can confirm if that is true. But she's up because she's so excited about her research and what it means for us as Circle of Cleft professionals. So if you're joining us for the first time today, welcome. We're so glad you're here. Just as a quick reminder, if this is your first webinar, the Circle of Cleft Professionals is really about facilitating this kind of collaboration and networking among cleft professionals, and especially on the topic that Allyn is focusing on this morning, multidisciplinary care in low and middle income countries, so really around cleft. We want to communicate the impact and learning that's happening in projects around the world, and we want to be a support to each other in terms of implementing comprehensive cleft care in every context. So this morning, as a quick reminder of who we are and where we're going, the agenda is a quick welcome here from Toronto. We're glad to have everyone. How the COCP, or the Circle of Cleft Professionals, is growing. We'll have Allyn Auslander's presentation, about 25 or 30 minutes, and then leaving, as always, a good amount of time for questions, comments, and discussion afterwards. As we'll hear, this is an ongoing research project, so I'm sure our questions will be helpful even as these next steps of the research unfold. And then we'll move from there to talking a little bit about what's happening next, including the philosophy of management of VPD, which is coming up next month as our webinar. So as a quick reminder for Zoom, if you haven't used it before, please do keep yourself on mute. Becca, my colleague and the special projects coordinator for the COCP, is here, and we'll try to keep managing some of the admin side to make sure the audio is strong. We will be recording this webinar and posting it to our Slack channel so that people who weren't able to make this time can continue to engage and learn and hear what the conversation was all about. As I mentioned, we are around the world, so 25 countries represented so far, over 123 members, and with a real range of all the comprehensive cleft care disciplines, from nutrition, speech, orthodontics, research, surgery. It's quite exciting. So without further ado, this morning, this webinar comes to us from one of our key supporters, and that's Operation Smile. Allyn Auslander has been working with Operation Smile as part of this research, and Operation Smile is one of the 9 organizations that's bringing you the COCP and the conversation that we're having this morning. So Allyn Auslander, as I mentioned, is in LA. She's a program manager for the International Programs Division of Plastic and Maxillofacial Surgery at Children's Hospital of Los Angeles. She's also a PhD candidate at the University of Southern California. Without further ado, I'll allow her to introduce a little bit of what her research is all about and why she's come to share with us this morning, this afternoon, or this evening about this international family study, understanding risk factors of cleft in low and middle income countries.
Perfect. Thank you so much. It's so nice to be with everyone this morning. It is definitely early for me, so please excuse my voice if it's a little bit of a morning voice. I'm just going to share my screen, so I'm going to disconnect. Everyone can see my PowerPoint? Yes, can someone just confirm that for me, please, before I start talking around it?
Yeah,
I can see.
We can see you. Okay, perfect. So, like Hugh mentioned, my name is Allyn. I am part of a collaboration between the University of Southern California, Children's Hospital Los Angeles, and Operation Smile. And we have started a case control study looking at both environmental, behavioral, and genetic causes of cleft in some of the populations Operation Smile works in. So I will spend the first part of my talk really talking about the study and how it came to be, because we found that to be honestly, for me, especially seeing the way other studies work, probably the most interesting part about what we do and what makes it so special. And then I'll talk about some of our more recent findings that we're really excited about. So the way, and this is, in Operation Smile, we always start by talking about, where the world is with surgery. And I know that I probably don't need to tell most likely anyone on the call this, but I like to always put a few of these facts up, which most of you know because they're staggering, because we know that the lack of access to surgery, kills more individuals than TB, HIV, and malaria combined. We know that it's affecting the majority of the planet, and that lack of access is completely disproportionate by region. We know how many surgeries we need, actually additional surgeries we need each year, and how many providers, and then how much of the global burden of disease this is affecting. And the reason that we like to start this way, and I always like to start this way, is because there are certain conditions where, we need to, and I think we can start thinking of surgery as a Band-Aid. And at Operation Smile, who's been treating cleft patients for 37 years, I think we're starting to look a little bit into, could this be prevented? Could we start looking deeper into understanding risk factors so that, as opposed to treating more clefts forever, where we'll not have enough providers and we'll probably not have the infrastructure, especially for those who are most likely to live with it for their entire lives, we could just prevent some of them, decrease the burden on the health systems, and make it so these children didn't have it in the first place. So again, for these presentations, I know that probably everyone on this call knows this, but I say these facts to comment on how we all know how common this is. We all know that millions are living in unrepaired cleft, especially in a lot of the countries that, I'm sure you all are from and Operation Smile works in. And the reason I put this number on there is that I was actually looking for a number in the US that, what does a cleft cost? And I found this in a singular paper, so I don't think I trust it. But it made me think that maybe we don't really know what a cleft costs. Maybe we know what it literally costs. Maybe we know what surgeries cost, and that differ by country. But we don't really know the cost to the individual, the cost to the society, and that's not something we can know. But it's something that's probably bigger than any of us, really realize. And then this is my favorite: is that when you read a lot of surgical papers, and sorry for all of you medical professionals, there's usually a line like this: cleft has a complex set of genetic and environmental risk factors. And it really just stops there because we still understand so little. So that's where this study comes into play, and where we're really hoping, to help. So we call our study the International Family Study. And like I said, it's this really unique partnership between a university, Premier Children's Hospital, and then Operation Smile. And so this is such a unique partnership, and I think it's probably one of the most, like I said, interesting parts about what we do. So you have, when you think about it, you have Operation Smile, who I'm sure most of you have heard of, and they've been working on the ground in these countries for over 30 years. They work with the ministries of health. They work with local professionals. They have all these relationships. The community trusts them. They have these networks, these populations, and it's really amazing. But then if you want to run, a top-level research study, you need so many other things that wouldn't make any sense for a nonprofit to invest in. So you need, for the genetic portion of our study, we're using the University of Southern California's labs, which I think just running one of the freezers that holds the samples costs, maybe $30,000 per year. Having all of the lab, and then you have the Department of Preventative Medicine. So I'm getting my PhD in epidemiology. So you have epidemiologists, biostatisticians, you have the ethical approval board. So in the US, that's called the IRB. And these things are all housed at USC. And because it's an academic institution, and we have myself at USC, we have a plastic surgeon at Children's Hospital Los Angeles, because we're in that network. All those services are for us to use. And we can bring these two things together to create this kind of perfect partnership where you have the doers on one side, and then you have the academics on the other. You have the I like to say the doers and the thinkers, even though both do both. But it comes together in the middle, and we actually have the ability to work in these countries where the community trusts us to not have to, as academics, go in and create all new relationships, and then Operation Smile not have to go in and try to become a research university to conduct research. And so we have the University of Southern California, Children's Hospital Los Angeles, and Operation Smile, which is this beautiful partnership of these big name organizations. But then what we've been able to do since the study started in 2011 is bring in the partners that really make it possible. So that's when we start bringing in local hospitals, local maternity wards, local universities whenever we can. And we're actually working with the heads of these hospitals, researchers at these universities, medical professionals at these universities and these hospitals to make this possible. And it's with their support and their involvement, both directly in helping us, set up approvals and collect data, but also, as being part of our research advisory committees, as helping us think about what are the causes of cleft or the risk factors for cleft that, we're maybe not thinking of because we are based in the United States. So it's this which has, made so much of our studies so interesting to work on it and so successful. And then there's the next level of partners, going down even another level, which is our local, our local team members, like I said. So this is Dr. Sylvia. She's a medical geneticist from Madagascar, and she has helped us think through our study and help us driven it so much more than I think anyone else could have, because she is there, she's on the ground, she understands the medicine, she understands the science, and then she understands the kids, which is the most important part. We also have local data collectors who have had cleft themselves, and they were Operation Smile patients at one point. And if you are asking a family these tough questions on a tough day during the mission, there's no one they trust more than someone sitting in front of them saying, I had a cleft, we're just here. We want to understand it more. We want to be able to answer your questions of why was my child born with a cleft? And then last, but certainly not least, we have our families, and they are, I think we're in the US a lot of times used to people, when you ask them to spend time doing a questionnaire, answering your questions, they're so hesitant, but they've been so kind to us and so pleasant and honestly so enthusiastic that an organization like Operation Smile, and we're not just focusing on giving them care, but we're saying, maybe you could help just a little bit down the line for a future child, for your child's children. Maybe we'll actually understand why this is happening by then. And maybe one day we'll be able to do something about it. So from that, the design of our study is a case trio study. So that means that on the mission, which is our cases, we collect from the moms, dads, and the cases. We do a pretty extensive questionnaire with the mother. It takes about 45 minutes. We ask about everything from prenatal exposures to the father's exposures, work history, possible exposure there. One of our most interesting things, which I'll talk about today, which is cooking habits, which is what I'm super interested in. And then we also collect saliva from the mother, father, and child. We use that to do our genetic analysis. The beautiful thing about saliva is that it doesn't need to be temperature controlled. It can sit on a shelf for 7 years, and those samples are really strong. We do the same thing in local maternity wards near Operation Smile mission sites. So we always use public wards to do our best to match our controls so they are comparable to our cases. And we go into, the maternity ward. We work with mothers who have just had their child, and the newborn is deemed healthy by a medical provider, and we do the exact same mom, dad, and child. So this sets us up to, on the bottom of that diagram, have a classic case control study with matched relatively population matched. And then it also sets us up to do trio analysis, which when you're looking at more high-level sequencing, so whole exome sequencing, whole genome sequencing, and you have the trio, this would allow us to really understand potential de novo mutations. And I will add to this as well, another thing that we've put in our study to do is when we find interesting families, we've done a few times with Operation Smile, so a family with multiple generations affected, we actually do have the infrastructure to collect from the whole family, and we've actually gone home with them to meet their other family members and look more at a complex family structure. We're currently in 8 of Operation Smile's countries. We try to spread them out geographically. So we are in Vietnam and the Philippines in Asia. We are in Honduras, Nicaragua, and Guatemala in Central America. And then we are in Morocco, the Congo, and Madagascar in Africa. Another, just kind of anecdotally, but I think as a researcher, these are very different places to work in, and it makes the study so impressive and really just speaks endlessly to Operation Smile's network that we are able to run the exact same study in each of these countries. So besides the fact that, of course, the questionnaires are translated into each language, but we have been able to train passionate data collectors in each place that are all involved. They understand the importance of consistency. They understand why we're doing the study, and we can get quality data across all 8 of these locations. We have a little over 16,000. These numbers are the unique genetic samples at the moment. So as you can see, it's just over 7,000 families, but it's about 16,000 samples. So it is, as far as we know, the most diverse, especially when you're thinking about low middle income countries, Cleft genetic database in the world. The reason there's so many in some and not in others is, of course, is time. So Vietnam was one of our first countries. They also have a lot of Cleft in the Operation Smile Vietnam. Hit the ground running with this, and is going to collect until we tell them to stop or until they run out of kits. And then Guatemala, as you can see, is our newest country. So those numbers are smallest, but we're currently working on kind of evening these out. So that we can be sufficiently powered in all of these countries to study what we want to. So it does create, it's a little, like I said, disproportionate right now, but it is a good ethnic breakdown, and that a lot of these, a lot of these countries, and you all know, just really are a lot of times forgotten in research. It's when I've been working on my dissertation and working on my PhD, it's like hundreds of Cleft papers that I have to sort through. But then when I'm like, okay, well, what if I only look at the countries that we're working in for this study? It comes up to be pretty much nothing. So we're really excited about this and the opportunities that we have to study really different ethnicities, especially from a genetics perspective. We have been able to publish with this study. If anyone's interested, I'm more than happy to send you the papers. But the reason I put this up is just to say that, we're adding to this gap in the research. And I think, which I'll go into more as I talk about my specific work, is that it's no different than people being left behind in receiving care. Is that, okay, sure, we may not be ready to prevent clefts yet. We may not be ready to, fully act on genetic data. But if we leave these patients out, they'll be just as left out and just as behind when the day comes that we can do that. And I think you have an organization like Operation Smile who has the access. You have our study team who's so passionate, and it's kind of the perfect storm. So a little bit into my research. So I'm looking at how different types of smoke exposure affect your risk of cleft. So I think the way we all think is maternal active smoking, also paternal smoking and environmental smoke. And then what I'm super interested in is women who are exposed to smoke from cooking. So the reason I put this up is not because we need to worry too much about the effect of women smoking, which if you look at the very bottom, it's about a 30% increased risk of cleft. But if you look on the side, this is the most recent meta-analysis looking at this data. It's from 2016, And the countries that it comes from are Finland, USA, 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 Sweden, Canada, Europe, USA, USA, Sweden, USA. So if you're talking about representing different ethnicities, different exposure profiles, we're doing pretty terribly. When you look at environmental tobacco smoke, it's slightly better. There's one study from Brazil. The sample size is pretty small, but it's okay. And there are a couple studies from China, which we have seen, and it's been published that there's a pretty different effect of smoking in China, and we don't know really, is that genetic predisposition, or could that possibly be a dose response, but we haven't really been able to study that yet. So what that leaves out almost completely is this smoke exposure from cooking. And I think a lot of us have probably seen it, we probably know, but 3 billion people are currently cooking with wood or charcoal. So where we've put all of this effort into maternal smoking during pregnancy, which goes down and down and down with education and is most common in developed countries, we have this exposure that's affecting 3 billion people, is causing a wide variety of different diseases, including adverse pregnancy outcomes, and it's actually been linked to stillbirth as well. But we've never studied it with respect to cleft, and it's killing 4.3 million people every year. That's 500,000 children under the age of 5. And like I said, that's from health complications, but it is associated with adverse pregnancy outcomes as well. And then what I thought was so funny is when I was researching cooking like this, it had the same stat: causes more death than HIV, AIDS, tuberculosis, and malaria combined. So we have something that we know from, especially when you're thinking about smoke, is it probably affecting a good majority of our patients. It's biologically plausible that it would have an effect on cleft, but because we've never worked in populations where the exposure is common, we've never been able to study it. So just again depicting, even in a lot of these countries where they do now have electricity, and a lot of our patients, I don't want to say a lot, but some of our patients may have electricity, they're still relying on biomass for cooking. So especially when you look at India, about 3 times the people who are without electricity are using biomass, Southeast Asia, etc. So our question, and my hypothesis is, could smoke exposure from cooking indoors over an open stove be a risk factor for cleft? And then I'm also curious about how this compares to other types of smoke exposure. So I used a sample of about 5,000 cases and controls. We did try to, like I said, the reality of collecting data in these countries is that it's not going to be perfect. We're not going to have the perfect number of cases to controls, but overall it is pretty close to half and half, even if it's not that way by country. So that's really exciting. And you can see the different years at the bottom that we've been collecting in each of these sites. So it is a different time period, but overall pretty consistent. We found some pretty expected things from our descriptive, characteristics. Our controls are mothers and fathers are more educated. They're more likely to be from a city, which we would know. And then one thing I did find interesting is if you look at family history of cleft, even though of course we expect it to be much higher in patients, it's only about twice as high. Which I would think that would actually be a little bit more extreme, so showing that our controls really they know what cleft is, they've had a family history of it, and they've seen it, which really speaks to the fact that the environment could play a role in cleft development. And then when we looked at smoke-related characteristics, my favorite thing is to look at the mother smoking, because the truth is this just isn't an exposure that is relevant to our patients. We had less than 1% of mothers reporting smoking prior to pregnancy, and almost no mothers reported smoking during pregnancy. And although this could be, women not wanting to admit they smoke or during pregnancy, the numbers were so low that in our analyses, I actually limited it to non-smoking mothers. So anyone that reported smoking is taken out of the analyses, so that should be unbiased. And these are my main results, and the only one that really matters, and I will leave this up for a moment if everyone wants to look at it, but is cooking. Even in my most adjusted model, which is on the far side of the table, we found that in our population, cooking indoors over this open flame is associated with about a 50% increase of risk. And my third model is controlled for all other types of smoking. So that's taking into account whether the father smokes, taking into account whether there's tobacco in the home, whether we adjusted for mother and father education to better balance our cases and controls. We adjusted for country, family history of cleft, whether they come from a rural or urban area, as well as alcohol consumption. So even after all of that, the only thing we found to be associated with an increased risk of cleft in our pretty large cohort was exposure to cooked smoke. So these are my results by country. Here, sample size does become an issue, and I'm so sorry, I should have mentioned this because you are all cleft professionals. This is looking at all clefts together. I did do separate analysis for cleft lip with or without palate, and then isolated cleft palate. As most of you would probably expect, all my results were slightly more extreme for cleft lip with or without palate, and then slightly closer to the null if it was isolated cleft palate. That did limit our sample size because about a third of our cases, as to be expected, were isolated cleft palate, but we do have all of our patients screened before we enter them into the study, so, and we only include non-syndromic patients. So even the isolated cleft palate patients are non-syndromic. And here sample size becomes an issue when we look at it by country, but what's really exciting is we see the trend pretty much the same for all the countries. Nicaragua is a data problem because there's so few controls, and when you adjust for a rural urban area, it creates a biased result. So I won't go too deep into that. And then, unfortunately, we also had to leave Madagascar off of the country analyses because Madagascar was so homogenous when it came to cooking practices. About over 95% of cases and controls reported cooking over an open flame. So there's nothing to, really be able to study there. But especially you see Vietnam, there's a pretty extreme result. It was over 2. The Philippines was about 1.5. The Congo was about 1.9. Honduras 1.4. Morocco just over 2. And again, the confidence limits are not all significant because of sample size, but the positive is that all the results, like I said, besides Nicaragua, are trending in the right direction. And then these are my results by cleft type. I'll leave these up just for a second to say that you can see on the left, and I think it should be your left as well, I'm assuming, cleft lip with or without palate. All of those results are a little more extreme. Congo, Honduras actually becomes significant. Philippines becomes pretty close, but all just a little bit higher than the all cleft, and then the cleft palate results are much closer to the null. So my conclusion, and I would say our lessons that I always like to end with, and what I feel are the major takeaways from our study, is to study the risk factors for cleft lip and palate in low resource populations. We need unique partnerships like this one. A study like this in 5 years would never be possible without every single person involved, without Operation Smile, without Children's Hospital LA, without the University of Southern California, without our in-country partners, and without our patients. This is a really exciting study because, like I said, there's just this huge gap in research for these countries, and we're so excited to be contributing to that and have this database that we're hoping, as we continue work on it, can be a resource for other researchers. We actually were able to be part of a paper that was published recently, and it was the first big cleft GWAS study in Africa, in Africans, and they found a gene that they thought was linked, and we were able to give them a small portion of our DNA for all of our Congo samples, which is what they were interested in, to validate their findings. And then they were able to validate their findings, and that was a resource that we had that we could offer and that we could share. So not just contributing to our own research, but contributing to other research as well. And I think this is, pretty straightforward, but it comes back to my point of, if we don't study all different populations, we will only find solutions for the populations we study. So looking at all of the studies that are out there where everything is almost based in Europeans, Americans, and mainly Caucasians, we're never going to find solutions for our patients. And we need to be thinking about that. And these things take time. I mean, we've collected these samples. It's only, at most a couple thousand families from Vietnam. And that's taken us 5 years with the infrastructure that Operation Smile had. So we don't want to think that, once we find a solution, we can just do this so quickly and then we'll find different solutions for different populations. We really need to, start sooner and make sure we're on top of that. And these are some of our, our results. We found that cooking over fire indoors, well water was found in our first paper, education level and family history have all been found to be risk factors in our populations. And 2 of those, cooking over fire indoors and well water, are not things that will ever be studied in developed countries. So if we don't study these populations, we can't study exposures that, are going to be completely left out of the literature. And we're really hoping that studies like this will be able to inform public health prevention. We are starting to look at, validating our findings about cooking, and then we can, as Operation Smile, maybe we can partner with a Clean Cook Stove organization who's already doing that great work, or we can just put a little bit more education behind it so that when women are pregnant, they cook less, something like that, and we really could start to think about cleft as preventable. Which is really exciting, and I'm so honored to be part of this work and work with an organization like Operation Smile. This is a picture of some of our study team. It's definitely not everyone. I think there's probably 7 or so countries represented in there. And yeah, this wouldn't be possible without such a cool partnership, and I'm happy to answer any questions. Thank you so much.
Allyn, it's Gare here.
Hi, Gare.
This is fascinating. As a pediatrician, I love this kind of thing. When you talked about the genetics, I was thinking that it's important to look at sub-Saharan populations, because I've heard so much about that. A lot of our studies done in both Caucasian and Asian populations do not show the same results in sub-Saharan African populations, and they think this is because of the long history of the peoples there. And we do know that cleft is less frequent in these populations, and I think it would be interesting, you probably have thought of this already, but to look at the populations in our African countries much closer.
Thank you, Dr. Strangeland. Yeah, Allyn, would you like to comment on that? And then I'll open it up for everyone also.
Yeah, of course. That's definitely something we thought about when you review the cleft literature. They've definitely found that the genes or the gene regions they've found that they think are associated with cleft in Caucasians are not the same as Asians, are not the same as Africans. So we do definitely think there's, a different genetic component. And like I said, we were able to participate in that GWAS, so that was in sub-Saharan Africa, which is super exciting. And then, we hope to keep expanding this study and adding countries. We're working on Malawi right now, but it's definitely something we're working on. And one of the studies we're actually working on, which we're super excited about, is a whole exome sequencing trio project in Madagascar. So I'm not sure if anyone's been to Madagascar, but they have such a unique genetic ancestry because they're partially coming from Africa and then partially coming from kind of like the Pacific Islands, which is totally different genetic causes of cleft and also the highest and lowest incidences put together. So hopefully there'll be some pretty exciting findings from that.
Thanks, Allyn. And thank you. Just to echo Dr. Strangeland's comments, fascinating. I mean, talk about a webinar topic that's really geared towards this group, all of us with a real interest in low and middle income countries, and thinking about, I think all of us have that spiel, well, if you're working on cleft, what causes cleft? And I think all of us probably echo that that disclaimer that you used at the beginning. Well, there's a mix of environmental and genetic factors, but thank you this morning for really diving into something, an assumption I guess people made that some of these studies that have been made, obviously, as Dr. Strangewood mentioned, focusing in on a Western context or a Northern context, and then really getting into some real data around the causes, the risk factors that are there, and starting to shift some of our perceptions about what is cleft a treatable condition? Is there something that we can be doing about that? So we do have a good amount of time, which is wonderful to discuss. So I will open the floor. If you would like to ask a question, you could either type it in, and we'll get that. We'll read that out for you. Or if you're able to activate your audio and video, I'll acknowledge you, and then you can ask your question, and we'll make the best use of this time. So as everyone's thinking, I do see that we have Ruben Ayala on the call this morning. Ruben, as Medical Director of Operation Smile, you've been very involved in sponsoring this research. How do you see some of Allyn's results and findings starting to inform Operation Smile strategy going forward?
Thanks for the opportunity, Hugh, and thank you so much, Allyn, for the presentation and all the work that the team at USC has carried out with partners around the world. For us, and I believe that most of us who are in this call will probably relate to this. A lot of times when we talk about what studies we have out there, most of our studies are based on what interventions we should undertake, what specific treatment guidelines we should follow. How can we improve some of the treatment or diagnostics that we have today? But very few of us necessarily are truly embedded into researching how to prevent this. So I apologize. That's my kid that I should be taking to school in a little bit. We can all relate to that. But I think as an organization, we look at these findings as an opportunity to go beyond what Operation Smile can do. Any knowledge that's generated for the purpose of treating or preventing clefts is knowledge that should be shared, and it offers an opportunity for all of us to engage in a different area, which is sort of influencing or lending that body of knowledge to authorities, to governments, to supporters, to sort of shift policy. So Allyn mentioned the clean stove movement. Based on these findings, we also have gone to first ladies of different countries to advocate for cooking stoves to be a part of the national plan to benefit families. I'm from Panama, and I remembered very vividly going to the well in my grandmother's house, and I remember very vividly going to the countryside and eating some delicious, yummy meals that were cooked indoors through biomass. So I guess my point is this will influence certainly our organization and how we use this information to try to help and assist in other areas. But I think it's been a good lesson for Operation Smile too, because we're all worried about how many more kids can we offer assistance to, and invest very little of our time and our resources into how we can prevent this. And so I would encourage any other of you who are with so many wonderful organizations to also engage with universities, with researchers, with people who can guide us to do really good ethical studies that will inform how we can prevent and take care of these children in the future.
Thank you, Ruben. Allyn, any response to Dr. Ayala?
No, I feel so lucky. I've got to work with Ruben a lot, and I saw a few of my other colleagues at OpSmile on the line. And I said this throughout my presentation, and it's been interesting to me as I've presented this work at a few conferences and in a few other venues. And most of the questions I've received have been around the partnership, because sadly it is a novel idea. But I think why would professors and why would universities try to make their own relationships, and why should nonprofits try to be genetic laboratories? We all have these amazing resources, and when you put them together, you really can have the whole package and do stuff like this. It's exciting.
Thank you. Other questions? Feel free to type. I hear a question from Naomi Leah. Thanks, Allyn, for your research findings. Interesting. This will go a long way to aid our research here in Uganda as well. Initially, my thought is cleft prevention, but now it makes sense knowing that in Uganda, a lot of people still have lots of smoke exposure, and I'm assuming especially in the home.
Yeah, so I actually read a really interesting, I'm gonna have to remember, it was a gene environment paper, and it was looking at, this finding of a specific gene that they found and maternal smoking during pregnancy. And they were saying, there was an interaction, it increased cleft risk by about 2.5%. But what was really interesting to me is they had one tiny paragraph at the bottom about health economics. And they pretty much said that with the prevalence of the gene at 25% in the population, and if you assumed maternal smoking prevalence at 25% or 15% in the population, and you assumed that this was a true finding, it could account for 6% of clefts. And my first thought was that wasn't very many. But then if you think about the effect that could have on, the local hospitals, they just have to do 6% less, just this little difference. That's really obviously people's lives, and it's so important. And then that's also, from a financial perspective, that's a huge amount of care that doesn't need to be given, and that's room to do 6% more surgeries of children that may have been missed. And even if it does play a small role, I think anything that we can do, especially something like a clean cook stove, where it's going to have so many other health benefits, and there's really no harm health-wise, even if it doesn't prevent cleft, even if it only prevents a couple. It's just a really exciting opportunity for us to start thinking a little differently.
Excellent. Thank you. One thing I was really drawn to in your presentation was really leveraging the volunteers. So Operation Smile participants, who had clefts themselves. I see on this call one of our colleagues from Myanmar who grew up with a cleft herself, is now one of the most effective mobilizers and accompanier and program managers in that region, just because she can speak to the experience. I want to say, I would like to say a little bit more about that partnership, especially with Operation Smile volunteers or former patients themselves, in getting good data and really getting usable data from families in these countries in which you're studying. Yeah,
so I think that, like I said, is one of the most important layers of our study, because it's great for us to go to some extent on these trips, but the truth is we usually literally can't talk to these patients because of language barriers. And what we end up doing is, I don't know if our project manager is actually on the call. His name is Freddie. He's in the Philippines right now. So usually Freddie goes to these countries, and he has just, created this global army of people there's so many people from med students to old Operation Smile patients who want to be involved in the mission and care so passionately, but aren't medical providers. And how do you involve these people? And research is something you can get them really excited about. We usually spend time with them before the mission, training them on how we collect the data on the questionnaire, making sure they understand it all. But the truth is that, at this point we have these data advocates. So like Dr. Sylvia in Madagascar, who we don't really need to go to Madagascar anymore. And she's a medical geneticist. She runs the study for us there. She does an incredible job. And, the families they take this so seriously, which is really amazing to see, because I think they have this level of social responsibility that I'm not sure we fully feel. And, to say the second, we say to them that, of course, this will never affect your care. It won't affect, we're asking them to participate, whether your child gets treatment. But we really want to one day understand why. And we're hoping we can, use your experience and understand your experience to get there. They're so supportive, and it's just incredible.
Thank you, Allyn. Dr. Shah from the western part of India thanks you for this wonderful presentation. And he brings up something that many of us know about and deal with all the time. So he says, in India, there are lots of myths regarding cleft incidents. In villages, they can say that because of an eclipse, a cleft occurs, and they can curse the mother for this deformity. How has bias and stigma affected your research, Allyn?
So I think, and this is, something we always need to take into account with our research is it hasn't overly affected our research because we're only working with patients who made it to Operation Smile. So our study is slightly biased in that we are seeing a select group of patients who have sought out care from Operation Smile. I don't really see that as a bias in the study because I don't think there's any reason they would be different from other patients. But of course, I don't know if Ruben or Guy or anyone else from Op Smile wants to speak to that. I know it's something that Operation Smile programs teams work so hard to educate and seek out patients and make sure that message is spread. And Operation Smile has some incredible programs around overcoming those sorts of things.
I would just ask that and maybe connect. So the question our colleague is asking is a very relevant one, because when we're trying to take care of kids who are sort of in the most remote areas, they are exposed to and they have different levels of access to information. They are exposed to a significant amount of bias. I'd actually like to tie that to the previous sort of observation in terms of how previous patients are now empowering others. So in some countries, we actually have patient counselors who are former Cleft patients, and they're the ones who are going to the communities to educate people. And there's endless stories about how they were able to shift the perceptions from bias to the information that enabled other people to seek care. So the father who took his own child, a former patient, and was able to explain his own kid to someone in the community, you can too get care. And you don't have to sort of live, hidden from the world. So it is two things. One is we all have this responsibility and desire and opportunity to do as much as we can to overcome those biases. They're significant. They do happen in vast amounts of the world, and certainly in some of the most remote areas. But we also have the opportunity to, as we engage with some of patients who grow, who get educated, to connect with them, because the empowerment that comes from them being able to take care of all their patients is amazing.
Thank you, Ruben. And obviously, I think Dr. Shaw was also referring to the idea of having research and studies like this that can go a long way in educating people that it isn't a curse, that it isn't something that the mother did wrong, that it isn't the eclipse of the moon, but there actually is science that would determine, have an influence on who's born with cleft and what can be done about it. We've got Aaron who comments, "Thank you, Allyn, for taking the time to present this work. I'm wondering if you've seen any studies that look at implementation of solutions, such as the clean cook stoves that you talked about, and then compare the pre and post birth rates. And do you think that's even a necessary step for this research?"
Yeah, so that's a great question and something we're thinking about. Also, I just want to comment, I'm still laughing over Dr. Shaw's question because I heard the word bias and immediately went into PhD student mode. I was like, oh, the work is biased. So a little bit of a different definition.
Stigma would have been a better word. Sorry,
yeah.
it was my use of that word that triggered that. Sorry.
Well, mine are heart attack. I'm joking. Yeah, so I think that's definitely something we're now starting to think about long term. There's been a lot of interesting research in cook stove implementation in certain communities because, interestingly, they've I'm sure some of you know, they've actually struggled with implementation because they give them for free. They're pretty sustainable, but families in a lot of situations have used them for a month or so and then have actually stopped using them for multiple reasons. Either they don't like the taste of the food as much, or some other reason. I don't want to say it breaks. I don't think that's been a huge problem, but there's been multiple other reasons, why they don't use the cook stove. So another way we see this research having an effect is, maybe when people are introducing clean cook stoves to families, they can say, here's another reason why you should use this, why this is important, and why this, might be a little more difficult for you, or your food might taste a little funny at first, but especially if you're pregnant or something like that, we can say this really, really matters. And then I do definitely hope that long term, maybe we could do some ecologic studies and see as population shift, as the incidence change. But that would also probably require a lot of really complex birth registries that I don't think we're there just yet, but hopefully the future for sure.
Thanks, Erin. Thanks, Allyn. Other questions? What occurs to you as you think about this kind of study on specific factors that would be affecting families in resource-constrained or low-income countries that might influence the incidence of cleft?
Are you asking me?
I was asking the group, but I'm happy for you to jump in again. I wanted you to be able to take a breath. You've done a great job so far. One thing that really stood out for me was the assumption, that the focus should be on smoking, and that in a Western context. Obviously, we hear a lot about public health around the risks of smoking for your child, et cetera, et cetera. But it was fascinating how you were able to really eliminate that as a factor. I mean, the numbers of mothers who are smoking was so low that there wasn't really a cause to continue to research that. And I think that passes a smell test, at least in my travels around the world. I wonder, was that a surprise to you, or what did you make of that as you continue to research, Allyn?
Yeah, no, that wasn't overly surprising. I think, most people have spent time in these countries. I've seen very few women smoking cigarettes. And I should clarify too, when I say smoking, in my analysis, we looked at, pipe smoke, cigar smoke, chewing tobacco. So we did look at a variety of tobacco products. And our numbers actually, they lined pretty much perfectly up with numbers reported by the World Health Organization, in that we do expect these numbers to be extremely low, which is why this research is so interesting, because the main risk factor for cleft, environmental risk factor for cleft that the world talks about, is one that's, irrelevant to maybe 3 or 4, 5 billion people.
Exciting, yeah. As you mentioned, and again, if anyone has any comments, we have just a couple minutes left, so feel free to type them in the chat or just signal that you'd like to ask them in person. You mentioned that as you started to present these research findings, one of the key discussion areas is around these partnerships. And my question is, if you were, say, a cleft center or a hospital with a cleft unit in a lower resource context, what would you recommend as the steps if you wanted to reach out to a university or start some of these partnerships? Where should someone look to start if they were interested in having their own patients be involved in something like this?
That's a great question, and I think something we've really started to think about as the studies grown and papers have started to be published. And I'm more than happy to answer any questions if anyone has any ideas on a very specific level. And then on a more general level, I think one of the reasons our study has been so successful is because the reason it's the University of Southern California is because we're using cleft providers that were already in Operation Smile network. So I would just say find someone who cares, who's passionate, any local university. I think one of our goals for the upcoming year is to really have a local researcher involved on each level. And I think especially looking at the way universities and research works, Operation Smile has helped a lot with the funding of this study, and there's plenty of researchers out there who are so excited to do this kind of work where you can really make an impact and make a difference and work with kids, but especially helping the actual researcher with the funding mechanism. I assume that most people would be beyond excited to work with you.
Thanks for that encouragement. A few more comments have come in. Ms. Panwanyudi from northern Thailand, who works primarily with indigenous Thai patients as well as from Laos and Myanmar, really, has been beating this drum, hoping that to push prevention as a much less costly form of treatment than providing afterwards, and inviting some work in northern Thailand soon. So you can keep that in your in your back pocket, Alan. Also, some of you will have seen Dr. Julio from southern Argentina. Has not commented even in Argentina, what we consider to be a middle-income country, that not too long ago, people didn't have gas to cook at home. And so in the rural areas, there still is a lot of cooking inside the home. And so commenting just how interesting this is and has opened his mind to thinking about different risk factors. There's a bit of a rush on comments here. I'll give you a second too. Dr. Shah has also commented that the Prime Minister Modi has also introduced new initiatives to try to give gas connections to villages, and this would be interesting to study as well. If that is something that's followed through with, what are the cases? What's the incidence before and after some of this policy is put in place?
Yeah, super interesting. So exciting.
Very good. Any final questions for Allyn? She's been very generous with her time and her answering this early morning. Okay, well, we'll move to a bit of a wrap up now. We've got one last question just before the end. This is from Myanmar. Thanks so much for this interesting research information. I had heard about smoke from cooking over a fire to be a risk factor, but I'm not so sure about that because so many people not so many people talk about that. But for her, she's saying this really puts a piece of the puzzle together because in Myanmar, in her community, people are all still cooking indoors with wood and charcoal. So it could be a fertile ground for future research in Myanmar.
I need someone to help me validate my findings, so I'm excited.
Okay, well, if you like, Gift, who is working there, is someone who has a great work as a program manager in Cleft work in Myanmar, so she might be the right person for you to speak to later. Great, well, thank you. That brings us towards the end of our seminar today, or webinar today. A huge thanks to Allyn Auslander. And really, this is research that's so effective and so meaningful for the circle of cleft professionals. And I think for me, at least, has really opened my mind to a bias that I had, which was bias in the good sense of not really thinking through how the research subjects had been selected, and that there are some risk factors, obviously, in the countries in which we work that are different from that in Canada. And so fascinating research today. So where do we go from here? I see some chats are still coming in, so we'd encourage you to take this discussion onto Slack. We will be uploading later today this whole webinar, so you can view it again, look at Allyn's slides, ask more questions. I know for some of us for whom English is a second language, watching it again can be helpful in really promoting comprehension. I commit that the TF team will be active in trying to answer or connect into some of those discussions. What's next? If you do have articles or resources that are helpful to you, even as we think about this element of genetics, and I know that Allyn referred to a bunch of helpful studies today, we will try and keep the Circle of Cleft Professional library accessible. I think we all heard this morning Allyn's, or this afternoon, this evening, Allyn's offer to connect this to a research study if this is a particular interest, that you can reach out to her. And then what's next? Well, coming up next month, we'll be looking at the philosophy and management of VPD with Dr. Brian Summerlad and Dr. Debbie Sell. I see Debbie on the call this morning. So glad you could join us. And that'll be October 28th. And we'll look forward to that. And then looking forward, just a little bit after that, our November workshop is happening soon after. That's Dr. Kate Crawley and Pam Sheeran from Smile Train, who will be talking about some of these outcomes and continuing challenges for promoting speech therapy for post-cleft palate repair in resource-constrained, low and middle-income country contexts. So do make time, book your calendar, make sure you're present for that, tell your friends, and we'll have a great discussion for that as well. So just to sum up, a huge thank you to one of our sponsors, Operation Smile, and contributors. Ruben was quite active on the call today, but also for connecting us to Allyn. Thank you to Allyn for sharing her research, and we'll hopefully see many more papers and much more good work as this is an ongoing study. If you do have any questions about how to get involved in the discussion board on Slack, we're here to help. We'd love to have that be an active place where people can research and find information to talk to with one another, and even develop some of these relationships that Allyn was recommending we get involved with in terms of meeting enthusiastic researchers who can help us with our work and really have some of this fruitful partnership, the way USC, Operation Smile, researchers like Allyn, and really Operation Smile staff and volunteers around the world have contributed to really unlock some new knowledge that can help us in our work in cleft, and in this case, potentially cleft prevention. So thank you very much for today. And if you do have any comments or feedback, please feel free to send us an email, info@cleftcircle.org. And that's it for today. Thanks so much. Bye, everybody.